For this morning's presentation, the state Quitlines and I wanted to describe progress on establishing formal referral programs between Quitline, CHCs, and PHAs. And what we wanted to do, I think you skipped one slide. There's a slide before this one. Next slide. Okay. Nope, stay on the referrals. It looks like one slide dropped off, and that was just the objectives for today's call. So let me just review those with you.
Here they are, Linda. They're on the first.
To review referral options overall and in the participating states. Next, to share with you which referral options state Quitlines are using, and then to discuss some of the successes and challenges and next steps. And if you could go to the slide with referrals on it, that would be great. So just to remind you, and we talked about this earlier in one of the earlier ECHO sessions, Quitlines get about 1 million calls a year from smokers, and referrals from healthcare have become a really important part of Quitline's mission to provide services to smokers who want to quit. You can see that the number of referrals from healthcare has increased from about 170,000 to well over 200,000, and they're an important part of the work and the outreach that Quitlines do. Next slide. This slide shows two of the most frequent types of referral that are used with healthcare providers. You can see that 100% of all state Quitlines use fax referral, and almost 90% of state Quitlines allow for email or online referral from healthcare providers. Next slide. The third type of referral program is electronic referral. This is a type of referral that started around 2012, 2013, and it's grown somewhat. About 45% of all state Quitlines have implemented electronic referral with healthcare providers. Electronic referral begins with the patient's electronic medical record and allows providers to make a direct referral through that record to the Quitline. This type of referral is a referral and also takes time. It takes a lot of IT staff time to implement e-referral. So it hasn't had quite the traction that the other types of referral programs have had. Next slide. So let's look at the types of referrals that are available through the state Quitlines participating in this project. You can see in California, Kentucky, and Pennsylvania, all three types of referral programs are offered. In Missouri, fax, email, and online referral are available, and they're working to implement e-referral. In South Carolina, fax and e-referral are available, and they're working to implement email and online referral. Next slide. So we wanted to share with you the successes, challenges, and next steps that the state Quitlines we're seeing. Let's start with the types of referral that's been implemented with both community health centers and PHAs. In California, they're not referring with PHAs and using electronic referral with the community health centers. In Kentucky, also self-referrals from the CHCs, and they're trying to monitor that through the intake survey question. Missouri's using fax and email referrals and also quick cards with the community health centers. In Pennsylvania, the cards are being used with PHAs, and the CHC is working on e-referral and also using cards to refer patients. And in South Carolina, they've successfully implemented fax referral and are working on e-referral. In terms of successes, California's already counting their referrals, so that's great. They're able to monitor those referrals. Kentucky, they've been able to integrate provider web referral into the workflow at the community health center. This is a huge accomplishment, and it takes both the community health center and Quitline to do that. They also have offered provider web referrals for PHA residents at community events. In Missouri, they really felt the partnership was an important success with all three partners participating. And they've implemented fax and email referral and are able to track those referrals, which is great. They also are working with Affinia to let them know about outcomes of referral. So they're doing that full cycle of getting a referral, following up with the patient, and then letting the healthcare provider know what happens as a result of that referral. In Pennsylvania, they were able to get the Quitline number on the patient discharge instructions. Again, just one more way to make sure that patient knows the number of the Quitline, which is great. And in South Carolina, they're testing e-referral with the CHC. So that's a big accomplishment as well. In terms of challenges, in California, workflow has been a challenge. Kentucky, time, and time especially for the community health worker to discuss cessation options with the patient. Missouri, also time, but this was provider time to actually make the referral. And in Pennsylvania and South Carolina, implementation of e-referral has been a challenge. And you can see the next steps in California, working primarily with the community health center. Kentucky, next steps focus on the public housing agency. Missouri is focusing both on the community health center and the PHA. In Pennsylvania, CHC focused, and again in South Carolina, CHC focused. So I want to stop at that point and see if each of the Quitlines would like to say a little something. And I'm going to start with California. Sharon?
Yeah, probably the main thing that I would say is that we with Curry, with our community health center, we do have a web-based referral system, and they go out to the various housing sites. And so we've been in discussion to have them be able to sign somebody up directly into the helpline while they're there in the person's presence. So that's probably the other thing that we're working on. You know, contact rate is always a difficulty, but we do a lot with small groups that want to do web referrals rather than the automated direct from the electronic medical records. So that's really what we're working on.
Great, thanks, Sharon. Kentucky?
I just want to add that one of our successes is that since April, we've been offering 8 weeks of free NRT to any participant from a public housing facility. And we're hoping to see that kind of boost calls from public housing residents.
Excellent, thank you. Leslie or Missouri?
No, I just was saying, Linda, that you did a wonderful job summarizing what we've been doing over the last few months. And we're just going to continue to strengthen that partnership with Affinia and, you know, keep reporting and increasing the number of referrals with among the public housing population.
Let's go to South Carolina and we'll follow up and see if anyone from Pennsylvania can comment. Katie?
Well, I wanted to thank Linda for the, I agree, this is a great overview. And all I wanted to say is that, you know, we really realize how important it is to customize. We have to have the ability for our Quitline vendor to customize with each particular EHR vendor that the health system works with. So we're kind of going through that right now with a little bit of challenges. And the providers, and I don't blame them at all, if we're telling them we're going electronic, then they want every step of the way to be electronic. They don't want to have to go any extra steps. And so we're trying to iron out some issues on the back end. The good thing is we are running test files, but every EHR vendor is different, and we have to just go with the flow. So this is why I was committed to trying to roll out some other electronic means with email, secure email, and secure online. And so we're hoping that we can at least give them options. We want to give these providers options and remove as many barriers as we can to help them make those referrals. And we too are trying to get, I appreciate the comment about the NRT. We offer up to 12 weeks of NRT in 4x4x4 shipments, but they have to stay engaged to continue getting it. But for Medicaid, they don't have to pay a dime for these medications, and they can get all 7 medications through Medicaid with no copay and no payment out of pocket. And we're trying to get the providers to take advantage of really prescribing and increasing their prescribing habits, especially with their uninsured and Medicaid patients. So that's what I wanted to add. I don't know whether Linda heard it, but thank y'all.
I did. Thank you, Katie. And I see that Cache and Lynn are both on from Pennsylvania. Do you have anything to add?
Hi. No, I don't. Thank you. Lynn?
Great. Thanks so much. So back to you, Becky. We're finished.
That's great. Thanks so much, Linda, and the Quitline. Thanks for participating. Sorry for the technical challenges. I don't know what's going on today, but we appreciate everyone's patience working through that. It's great to hear the successes, challenges. Katie, I think your thoughts on the EHRs and how challenging the various vendors are, I think we all can relate to that and understand, and it's great to hear about the different ways you're looking at that. We have like a minute for question and answer in this part of our time together. Are there any questions that anybody'd like to ask, either Linda or one of the Quitlines, to clarify anything about their experiences with the referral process?
And Jamie asked how PHINIA is getting the information back from the Quitline on referred patients. And they answered that the Quitline sends an email with the update.
Oh, cool. So that sounds like, let me make sure I got this right. So PHINIA refers patients. The Quitline sends an email back to PHINIA to know who has followed up and actually called the Quitline. Is that right?
So, yeah, so Valerie, I think you said through the fax referral participant outcome report. So in other words, PHINIA would fax the Quitline a referral, and then an email goes back to PHINIA with specific patient information.
Yeah, so this is Linda. The way fax referral usually works is the provider sends the referral to the Quitline calls the patient, and then the follow-up that goes back to the provider is information on whether they were able to reach the patient and whether the patient agreed to be in services. We do follow-up usually 7 months after a person starts services, and that information would not probably be provided back to the provider, but they would know the status of the patient if they enrolled and if after treatment they were smoke-free.
That's great. Thanks, Linda. Thanks for clarifying. That seems really helpful to have the immediate report back around who's contacted, how the connection to the Quitline worked. So that's great, like closing the referral loop.